My name's Kelly Cox, and I work for the International Myeloma Foundation here in Los Angeles. I'm coming to you via webcam from our main office, and I'd like to welcome you to the Regional Community Workshop. Today is a special day. We have a great group of doctors and a nurse from our Nurse Leadership Board. You'll see them coming up shortly. First and foremost, I'd like to thank our sponsors, Bristol Squibb, GSK, Janssen, Karyopharm, and Oncopeptides. These folks really help us out through these programs, and I'm very grateful for them doing so. Today, it's a virtual program. Normally, in the pre-pandemic, I'd come there and have a program there with two great people helping me out, and a special shout out goes to Cindy Ralston and Wendy Thomas, who run the support group there and do a great job, and I'm very grateful. Our attendance is pretty strong, and I know that has a lot to do with you too. So let's go into some details here. I have to hear from you, and I can't hear from you unless you do the feedback survey. It will just take you a couple minutes. There's just a couple questions, but I need to hear from you, and so do we, so that we can keep bringing these wonderful programs to you and with special guests. Now, today's meeting in our agenda here, our workshop, you'll see that our first Myeloma 101 in front therapy is done by Sid Ganguly at the University of Kansas. Then we'll have some question and answering, so hold your questions. You can type them in the question box, but just give it a sec once we'll do the answering right after his talk. Then we have about a 10-minute stretch, a little less than that. Then we go into relapse therapy and clinical trials with Abdallah at the University of Kansas Center. Great talk. Question and answers, the panel will answer. You'll have already asked your questions. And then how to manage myeloma symptoms and side effects. Kevin Brigle, PhD, MP, VCU, Massey Cancer Center. I always have a hard time getting that out. Then we have the question and answer after that with the panel. Next slide. The first talk today is Myeloma 101 in Frontline Therapy. Now, in the old days, we'd use a number 2 pencil and a legal pad, but some of you have computers and you'll do it that way. But remember, if you miss some pieces here on this presentation, the presentation will be on our website shortly, and you'll know about it if you, as a registered guest, and by filling out the survey form. So without further ado, take it away, Sid.
Thank you, and good morning to everybody. The big kudos goes to Kelly and IMF for bringing this wonderful program to our community, to our patient, and to our institution. And we have been doing it almost every year. I think the last year, because of the COVID, we missed it. But prior to that, we had in-person meetings. And this year, we are meeting virtually. And hopefully, maybe next year, we'll have, again, in-person meeting. So with that, without any further ado, I'll just go ahead and get started. I was instructed to talk about Myeloma 101, basically to make a segue for the treatment for de novo diagnosis, and then moving on to Dr. Abdallah's topic of relapsed refractory disease states. So multiple myeloma is a cancer of our immune system. And the name of the cancer cell is called plasma cell. And on this slide, you can see some normal and some not so normal looking plasma cells. Normally, we all have plasma cells. You have it, I have it. And normally, it makes antibodies, normal antibodies to fight off infections. For some reason, if the normal plasma cells become abnormal, either by genetic mutations or translocations, environmental factors, causes we may never understand, a clone emerges. It's not that all plasma cells become malignant. Some of the plasma cells become malignant, and then they start making an abnormal antibody. They start proliferating, and they expand the bone marrow. So one can see those abnormal antibodies in the blood by a special test called serum protein electrophoresis, which is seen on the left upper panel, where you can see an abnormal spike. And that is the abnormal protein made by abnormal plasma cells. We call it M spike or monoclonal spike. Now, the electrophoresis does not tell me what kind of myeloma we have. And for that, we go to the next step called serum immunofixation. And serum immunofixation gives us the structure of the immunoglobulin, which is the antibody, the M spike, and it could be various kinds, IgG, IgA, IgM, various kinds. And there are two free light chains, Greek letter kappa or lambda. So based on those, we can tell the abnormal antibody's specificity of either IgG kappa or IgA lambda. And as you can see, these abnormal plasma cells proliferate inside the bone marrow. It sometimes eats away through the cortical bone, leaving behind some small lucent areas. We call it osteolytic lesions, which are quite characteristic of a symptomatic myeloma. Unfortunately, some of them break through the bone, and I have had patients presenting first time with acute onset of back pain and vertebral fracture. And the symptoms of myeloma at that time could be related to overcrowding of the bone marrow that leads to anemia or low blood counts, the abnormal proteins getting filtered through the kidney and clogging the kidney tubules, decreasing the kidney function, bone damage we talked about, and increased bone turnover. All of them make the multiple myeloma symptomatic. Now, old days, when we were in med school, there were not much treatment, and multiple myeloma used to be fatal within 2.5 to 3 years. But now we have made a lot of progress in the treatment, and a lot of patients with multiple myeloma are living their almost near normal life. But interestingly, this plasma cell process starts or dates back years before it becomes symptomatic. And there have been really good studies from Veterans Administration's hospital system that showed a person today's myeloma probably started with something called monoclonal gammopathy of unknown significance 6, 8, 10, 12 years ago. And then some of them progress, some of them don't. They just stay as MGUS. Some of them may progress to smoldering myeloma, which has more than 10% of those plasma cells inside the bone marrow, but still we do not have any of the symptoms. And then eventually 50 to 80% of them can spill out to be an active myeloma, and then it goes through symptomatic phases of response, relapse, and eventually some of them, if not treated properly or because of really serious mutations or genetic abnormalities inside the plasma cells, could be refractory. But we had made real big progress. And as I was telling you, that when I was in med school, at that time, an average life expectancy was around 2.5 to 3 years. But now it is not unusual in my practice to see patients 15, 20 years still doing very well. And as you can see, the survival in myeloma over the several decades actually have improved. And now, in the most recent one, it seems that at least 15 to 20% of the patients are getting a plateau. Plateau means they have no sign of any myeloma 9, 10, 12 years after the diagnosis. Are they cured? I hope so. I'm usually very cautiously telling them most likely you're cured, but I still would not stop at 15 to 20%. We need to keep pushing the envelope where majority of our patients can use the word cure in myeloma. And you can hear from Dr. Abdallah that the day is not too far. I mean, I'm really seeing the future as quite bright. And that is because of an explosion of research and new therapy in the myeloma. Again, way back in 50s and 60s, we did not have much treatment except melphalan and prednisone. Then the transplant came, and transplant was a paradigm shift. Many patients went into deep remission, MRD negative status with transplant. And then the novel therapies, and most recently, this is the era of immunotherapy, monoclonal antibodies, BiTE, and now cellular immunotherapy, especially CAR T. So I, again, going to reiterate, the future appears to be quite bright as far as the diagnosis and treatment of this devastating disease. Now, stages of myeloma treatment. When we get diagnosed with multiple myeloma, it is an ongoing therapy. If we're not promising a cure, our promise is deeper the remission, longer the remission lasts. So we look at a patient and we say if the patient is transplant eligible or not transplant eligible. And based on that, we do transplantation, but initially we do induction and then followed by maintenance. So I always say that the care of myeloma is almost like a weed control unit in your backyard, and that gets little chuckle out of our patients. But I say, yeah, actually it is on the YouTube. You can look it up, Ganguly lawn care myeloma, and it will show me talking about this very basic concept. So what do I mean by that? Say 10, 12 years ago, somebody did not have myeloma and had a fantastic backyard. Now diagnosed with myeloma, the bone marrow has abnormal plasma cells, and the backyard is full of wheat. Well, go to the physician, and the doctor gives Revlimid, Velcade, dexamethasone, aka plasma cell killer. Plasma cell killers are like weed killer in the backyard. After 4 or 5 cycles, the bone marrow looks much better, near remission, very good partial remission, but the dandelions are still present 1 or 2 in the backyard, but most importantly, the roots of the dandelions are still there. But it is much better than before. So I have to say that the oncologist has done a great job gardening your bone marrow. Don't tell that I said that, but gardening. But then you come to the transplanter, and I call myself not a gardener. I'm a lawn renovator. If somebody is in the Kansas City area, they would know how the grass-fed man from Santa Fe and 135 comes online and tells you to strip the lawn and start fresh. And that's exactly what we do. We collect the stem cells, aka grass seed. We give high-dose chemotherapy to clean up the bone marrow and the residual plasma cells, and the backyard gets completely barren, and then we reseed the bone marrow, reseed the backyard with healthy stem cells that we have already collected, and let it grow, and now it will be a lush green lawn, hopefully without any dandelion. And that's the concept of the myeloma. But again, you would not leave your lawn without a spring and fall maintenance. So you do need a maintenance program, even if we do lawn renovation, aka stem cell transplantation. And the goal is to get to minimal residual disease where we cannot see any roots of the myeloma. So when a patient presents, the body probably has almost 1 trillion cancer cells. The proverbial iceberg model where you can see symptomatic myeloma. But deep down, when we are in the stringent complete remission, we still have significant amount of myeloma cells. And our goal is to push it down further to almost undetectable 1 in a million, like an NGS CR. And eventually, I still think 15 to 20% patients may hit the target of cure, and future maybe even more. So our goal is MRD negativity, minimal residual disease negativity. That's our goal. How do we get there? There are a lot of questions that are asked. Are we going to use 2 drugs, 3 drugs, and now 4 drugs? And if we use 3 or 4 drugs, which are the drugs? And then we talked about the role of transplant and maintenance and MRD. This was an eloquent study by Swag, which showed compared to Revlimid Dex versus Revlimid Velcade Dex, means doublet versus triplet, clearly triplet was the winner. So the standard of care right now in United States in a patient with newly diagnosed myeloma should be a triplet. not a doublet. Now, do I not ever use doublet? Of course I do. But that depends on the patient criteria, frailty, other comorbidities, kidney counts. But usually, newly diagnosed patients should be given a triplet. And then comes the era of immunotherapy. And daratumumab is one of the monoclonal antibodies that are against the myeloma cells. And now we also have isatuximab, another monoclonal antibody now approved in the treatment for multiple myeloma. Now, these drugs are usually not used upfront, except daratumumab is now approved in transplant ineligible patients, not transplant eligible patients with Revlimid and Dex. So Dara Rev Dex is now FDA approved for transplant ineligible patients, where it is compared to Rev Dex, and clearly it shows daratumumab is superior in the response as well as in the progression-free survival. Now, because it is FDA approved for transplant ineligible patients, I have started seeing some of my patients getting daratumumab upfront and then referred to me for potential transplantation. So you would be seeing that happening in the community, but really Dara-RD is for transplant ineligible patient. For transplant eligible patient, there is a combination that is called Dara-VMP, which is used more frequently in Europe compared to United States. We use Dara-RVD sometimes in our patients. And you may have heard about that quad combination. Quad combination is Dara with RVD. Now, this is the trial we at KU were a part of it, called Griffin-Tyre, where Dara-RVD was compared to RVD, and then the patients got transplanted, then had some consolidation and maintenance either with Dara-Rev or Rev. And this is a very recent trial. We do not have a long-term data. We do have response criteria, and clearly you can see the responses of the Dara-RVD compared to RVD is better. And as we continue the consolidation phase, the depth of response increases on the Dara-RVD compared to the RVD. Is this the future standard of care? I do not know. I personally do not use quad right up front, but if somebody uses, nothing wrong with that if the insurance approves it. I personally like to keep the daratumumab for future use, but this is something that is coming. The other question that I get heard is, I have used the chemo, how long do I take the chemo, especially if I'm not going for the transplant? And that question was answered by this particular trial called the FIRST trial, where an Revlimid and low-dose dexamethasone was continued until disease progression compared to 2 fixed cycles. And clearly, the RD continuous was much better compared to the relapse or the progression than stopping the treatment. So if somebody decides not to undergo transplant, I usually continue this at least for 8 to 12 months, and then based on the tolerability, go to the Revlimid continuously or Revlimid with low-dose dex. So continuous treatment is much better than fixed treatment. And I mentioned autologous transplantation improves progression-free survival in a transplant-eligible patient. If somebody is transplant-ineligible, then definitely that would not apply. So this is a HOVON trial, very recent trial, where patients received Cybordi, the Velcade, Cytoxan, and Dex, followed by stem cell collection, then chemo versus transplant, and then randomized to consolidation or no consolidation, and then maintenance. Bottom line is chemo ongoing versus transplant. And here you can see the progression-free survival all over the board was better with the transplant compared to non-transplant. And so the trial conclusion was upfront transplantation significantly prolonged PFS. Now, the purists will say, how about the overall survival? And I have to admit, yes, the overall survival has not been shown to be better with transplantation, both in European as well as US trials. But the follow-up to show the overall response in a disease like multiple myeloma or follicular lymphoma may take years to show. And also with many, many new drugs available, and quickly if somebody has a disease progression, changing the therapy, we may not ever be able to show overall survival advantage. So I usually tell my patients, if somebody gets a transplant, then your chance of remaining in remission is longer with transplant than without transplant. So the same thing is asked by this question. My doctor told me my myeloma is in good remission. Should I go for transplant now? Or should I harvest and hold the stem cells and do the transplant when the disease progresses? And that question was answered by this trial called IFM trial and the Dana-Farber trial, now a very good CTN trial. The IFM, which is the French, the European part of the trial, is complete and is reported, where people had gotten the RVD and then the transplant and then RVD versus only chemo and transplant at relapse. And the answer is, again, very clear. People who got the transplant, they had a better progression-free survival. So the conclusion of even that trial is that transplant is safe. The transplant-related mortality is probably less than 1% now, and it is associated with improved 4-year progression-free survival. One other fact that came out is minimal residual disease negativity. If somebody is minimal residual disease negative, their progression is far less compared to if somebody still is MRD positive. And with the transplant, the chance of getting MRD negativity is higher than not getting the transplant. So I am a proponent that if somebody is transplant eligible, should undergo transplant now rather than delayed, because delay may mean the disease may mutate, it may get more resistant, a lot of things can happen. Many patients actually never get to the transplant. So I would say go for the transplant if you are transplant eligible. But is there a cure? We talked about this iceberg model, and clearly you can see deeper the remission, the chance of the disease coming back is delayed. So with transplant, average progression maybe 3 to 5 years. And if we can continue with our maintenance or consolidation and keep the MRD negative status, maybe we'll be pushing the envelope, and that 15 to 20% of cure number might increase in future. So we need to keep on trying to get rid of this last MRD positive clones in the bone marrow of our patients. And I think that's probably will be the future plan for all the researchers. This is the LEN maintenance after high-dose transplant, and clearly we talked about that unless you do something to get the weeds off the ground after the lawn renovation, the weeds will come back. And that clearly shows after 7 years of follow-up, an overall survival advantage if somebody gets some form of maintenance compared to somebody who does not get a maintenance. Now, there are different kinds of myeloma. And at these days and ages, we have capability of genetic profiling and standard risk and high risk categories with cytogenetics and gene expression profiling. So in this trial, the high risk category patients had a very high risk of relapse. Those patients were placed on maintenance that was not only Revlimid, but also a proteasome inhibitor like Velcade. So after the transplant, 90 days, 80 days after, the Emory group from Atlanta, Georgia, decided to start low-dose Revlimid, like 10 milligram, low-dose bortezomib, and steroid. I call it RVD light or diet RVD, low dose. And that clearly showed almost 90% positive response after 3 years on these high-risk patients with multiple myeloma. Now, there have been some randomized trials that really could not show the difference, but I think if somebody has high-risk chromosomes, they should consider maintenance not only with Revlimid, but also with a proteasome inhibitor. Now, that has gone taken to another level that we are running. Dr. Abdallah was the principal investigator of this trial, where people are getting not only Len maintenance, but Len-Dara maintenance. And the next question is, if I am MRD negative, do I really need to continue the maintenance forever? Well, this trial is trying to answer that. If somebody is MRD negative for 2 years, can we stop the maintenance therapy? We don't have the answer yet, but we will get the answer in future. Are there patients where we do not need to have any more maintenance therapy and they are cured? Well, I hope so. So this is my last slide and my most favorite slide, that relative survival ratio. And I've been showing this slide in every one of my talk. Relative survival ratio means what's my chance of living in future decades compared to my age, ethnicity, and my risk factors. So for example, if somebody is 60-year-old and has multiple heart lung conditions, the relative survival ratio may be lower than the general population being 1.0. So going back to myeloma, when people are diagnosed upfront with 1 trillion cancer cells, and if we don't do anything, think about 1960s and 70s, the relative survival ratio was just few months, 0.1, 0.2 compared to the general population. But now we have the novel therapy, RVD. Then we have the transplant. The relative ratio goes up, 0.6, 0.7. Now we have the maintenance. Now we have the immunotherapy. We have the CAR T. And we have some patients where the relative ratio now is approaching general population. So they're living like anybody else with a diagnosis of multiple myeloma, but no sign of the multiple myeloma. And that's going to be the future. And that's the dream of all myeloma doctors who treat patients with this cancer. So take-home message, 15, I would say not 10 to 15, maybe 15 to 20% of the patients may be cured by modern treatment. I still think early and upfront transplantation is the standard of care for transplant-eligible patients, and hence an early referral to a transplant center should also be the standard. And risk stratification, personalized medicine, like not every drug is for everybody. We need to think about a patient and take care of the patient holistically. Not only I'm taking care of the cancer, I'm also taking care of their life, their socioeconomic status, their grandchildren's birthday party. All of those should be in our mind when we devise a treatment strategy for our patients. And with that, I'm going to say that we were in 1950s, and now we moved on to more genetic understanding, and now we're really talking about the future of personalized medicine, giving the treatment that a person really needs with one goal: can we cure this disease? And with that, I will probably say thank you and end my talk.
Deck, and especially the last slide. I've been doing this with the International Myeloma Foundation for 20 years. And I remember when they sent me out to go talk to support groups, they gave me a little card and it said thalidomide on it. I darn near quit the foundation, but then I heard about a lot of things coming down the pipeline. And I'm hearing them come down now, so it's really something. Hey, Sid, can you see the questions?
I can see the questions, and actually the questions are 987. So why don't I can see up to 5.
Okay.
I cannot see question number 1, 2, 3, 4. So why don't I answer the question that I can see? The last question that I have is, are there new treatment options for patients with smoldering myeloma who are not high risk? First, let me talk about high-risk smoldering myeloma. The standard of care still in 2021 is no treatment. But you're right. Patients with high-risk smoldering myeloma would have a very high risk of progressing to multiple myeloma. So there are many centers that are starting treatment with Revlimid, Dex. Actually, the Spanish trial showed overall survival advantage. We have a trial with Dr. Abdallah where we are using multiple treatments and even collecting the stem cells and randomization for high-risk myeloma. I know of no treatment options for patients without high risk, because remember, treatments are not without risk either, and not everybody will be progressing to multiple myeloma. So you would be treating 50% of the patients without high-risk multiple myeloma with potentially harmful chemotherapy who would never, ever develop myeloma. So I would not recommend any treatment option for non-high-risk multiple myeloma.
Do you see,
so
Robert?
I cannot see question 1, 2, 3, 4. So I'm only seeing the last questions. I see, can you go over the factors determining if a patient is transplant eligible? Absolutely. Basically, transplant eligibility is whether if somebody has the capability and functional status to undergo high-dose therapy. So old days, we used to put age as a marker. Age is not a bar. It is not the chronological age. It is a physiological age. I have that transplant in 81-year-old who can easily beat me in a cross-country or arm wrestle, which is, by the way, not a big thing to beat me. But I have not run transplant in a 45-year-old who has multiple comorbidities. So we also institute frailty. So every patient prior to the transplantation, especially 60 plus, undergoes a very extensive frailty testing in our clinic for the transplant eligibility. So transplant eligibility based on functional status, frailty, and other comorbidities. So depending on that, we decide. And it's a very thorough checklist.
Okay. Do you see the one I received at first transplant at Cyborg D with Revlimid maintenance, number 7?
Number 7. Okay. Number 7. I received first treatment Cyborg D with Revlimid maintenance, VGPR for 3 years, then second treatment KSI-D with CR for 3.5 years. Can I go back to one of these treatments or try something else on my third treatment? Okay, so no transplant, 65 years old. So this is a question about the relapsed setting, and I think it is fair to have these questions for Dr. Abdallah or for the panel. So I would like to entertain questions pertaining to 101 or upfront. Otherwise, Dr. Abdallah should have.
Yeah, let's wait for him to do his talk, and then we can go from there. One other one, 11. How should smoldering myeloma?
So I have a question is, please clarify again the difference between low-risk smoldering and high-risk smoldering myeloma. It's a very good question. So as you know, there are some smoldering myelomas that we used to call smoldering before are now myeloma because of the myeloma defining events, or MDE. The 3 myeloma defining events, that means the patients are otherwise asymptomatic, would be more than 60% plasma cells in the bone marrow. If the involved versus uninvolved free light chain ratio is greater than 100, or an MRI showing more than 1 lesions, each more than 5 millimeter in size in the bone, those patients will have more than 80% chance of progressing. Now, if somebody with smoldering myeloma has the M spike more than 2 gram, the ratio is more than 20, and if the bone marrow has more than 20% plasma cells, so they are not myeloma defining event, but they are potentially could be considered as high risk. We call it 20-20 criteria. 20% plasma cells, 2-gram protein, and greater than 20 ratio. So there are various factors that are involved in classifying smoldering myeloma into the standard risk versus high risk. And based on that, the clinical trials have been designed.
Okay. And let's do this with the last question. How do patients with multiple myeloma know they are cured over 5 or 10 years or longer under your protocol?
This is a fantastic question. I really, really like to answer this question as my maybe time constraint, my last question. So the answer to that question is not known, but there are data that suggests that if somebody is in stringent complete remission or MRD negative, at least for 8 to 9 years. There are papers from Arkansas, and Dr. Abdallah was present when this paper was ready in Arkansas, that those patients hardly ever relapse. So my answer to the question is, if somebody is MRD negative for 5 or 8 years beyond the treatment, I think very cautiously we can stop the maintenance and monitor. But I'm still not convinced that the answer and the jury is out. And the reason is this. In the IMF trial, I wish I had the slides. There were slides of MRD negative patients and slides of MRD positive patients. And clearly, MRD positive patients relapsed more. But the patients who were MRD negative, their curve was looking very nice and up there. But even then, there were patients that relapsed over subsequent years. So I'll be extremely cautious if somebody's MRD negative and we stop the treatment. We need to monitor them. And MRD negativity is not just one-time snapshot. If somebody is MRD negative for subsequent tests, like 1 or 2 years, then I feel more comfortable of stopping the therapy and wait and watch, and then maybe after 5 years we can start using the word cure. Still, it is in the realm of a future crystal ball, the proverbial crystal ball. This is my hope that they are cured, but we do not have the confirmatory data yet. But the curves are very, very positive. After 5 to 10 years, MRD negative or stringent complete remission, the chance of relapse is very low.
Wow, that's very exciting. I think that your presentation covered a lot of information. I just wanted to thank you for taking the time on a Saturday, and we look forward to your additional comments as the day goes on.
So there are many other questions. We can always take it at the end as a panel.
Yes, that'll be fine. We'll wrap that up there. So we'll save the questions and you'll see them. Now, Dr. Abdallah is going to talk about relapse therapy and clinical trials. So in his question and answering session, he will answer some of those questions. So just stand by and be patient, and don't think about those questions, and just listen to his presentation, then after which we'll go into Q&A. Dr. Abdallah, thank you, and take it away.
Thank you very much, and thank you for inviting me, as usual, to this annual meeting. I know it's a different scenario because this is virtual that we're doing, and I know before we talk about the relapsed myeloma, I would like to acknowledge Dr. Ganguly. He gave a great and outstanding lecture today, Myeloma 101. And he is actually one of my mentors, who actually brought me from University of Arkansas. So I really always enjoy not only working with him, also learning from him. So I always learn a lot of great stuff from his lecture. So he's one of my best mentors I ever actually worked with in the past few years. So as much as it's kind of like that great connection, he's also leaving our university to go to Houston. So it's going to be a big loss for KU Medical Center, but he's one of the best mentors I would like to appreciate and acknowledge. Today we're going to talk about relapsed myeloma and also the clinical trials, and I will actually going to try to answer some of the questions that was actually brought up. But as we talked about that, we get the diagnosis of myeloma, we treat the myeloma, we put the patients on remission. The major question is that what's the thing that happened after that? Patients will relapse. the majority of the patient will relapse. And otherwise, I mean, we would actually say that these patients have different types of relapse. And the big question patients ask us, how does the relapse present? And we always tell the patients it depends on how they come by. So some of the patients will relapse like what we call the typical myeloma presentations with new bone lesions, possible renal failure, possible patients having anemia. Some of the patients, we will find it by actually the surveillance that we do. We check their myeloma markers, the free light chain, the serum M protein, very closely in order for us to kind of identify if these patients are relapsing. And if I start seeing these myeloma markers increasing, by chance, I will consider these patients are relapsed. I will consider maybe doing bone marrow biopsies, imaging studies, just to make sure I'm not I'm evaluating the burden of the disease. But I will not wait till they actually develop any kind of end organ damage. Sometimes these patients, unfortunately, incidental findings. We do an imaging studies like a yearly or something like that, and we find a new soft tissue, a plasmacytoma, and this plasmacytoma is confirmed with a biopsy, even with the myeloma markers being low. So this is actually another form of relapsed myeloma that we see it in patients. And a rare form of myeloma, relapsed myeloma, is a plasma cell leukemia, when you start seeing like some plasma cells, these abnormal plasma cells in the bloodstream, and that's one of the worst types of relapse of multiple myeloma. Anyhow, when you have that, you need to actually start thinking about the strategy of putting the patient back in remission. Yes, we try to think about that to get the patient back to remission. However, we have a lot of options of therapy, but it's not an easy way to go ahead and choose any option of therapy and just pick up this regimen and put the patient on this treatment. There's a lot of factors that really play a big role in treatment of multiple myeloma or deciding what triplet therapy or what medication we use for relapsed myeloma. So one of them is we look at the patient, any kind of the patient-related conditions like the fitness, comorbidities. We evaluate that. If the patient have any possibility of decompensated heart failure or acute coronary syndrome, liver failure, how's their performance status, what's their social situations, and also their preference. Some patients have preference that they travel a lot and they would like less visits to the infusion center. So we try to pick up these things and try to adapt it. Therapy related is also sometimes play a big role. What kind of treatment the patient received in the past? How is the response for these patients? What kind of side effects they develop? So sometimes patients had Revlimid and they barely tolerated for 3 months because they have major side effects like fever, chills, or rash, or maybe anaphylactic reaction. So it doesn't make any sense to try any of the Revlimid or any immune modulatory drugs in the future. And disease related, what type of relapse the patient have, and sometimes we look at the cytogenetics and the disease burden that we'd like to kind of like evaluate. So there's a lot of factors that a myeloma doctor or an oncologist have to actually look at in order to make a decision what type of therapy they're going to use for this relapsed refractory myeloma. Now, saying so, in multiple myeloma and relapsed myeloma, there's many classes of treatment that we have, and every class really represent a very great option for the myeloma patients. So you have immunomodulatory drugs, the thalidomide, which is an old drug. We don't use it very often anymore. The Revlimid and the pomalidomide, we use it very often. The proteasome inhibitor, that is Velcade or pertuzumab, carfilzomib, and ixazomib, or the other name is Ninlaro, which is the oral form of the pertuzumab. Steroids, of course, you have to add that for all these patients. Hydac, which is panopinostat, it's rarely that we use for this for our patients. But the newer treatments that now we're seeing is the monoclonal antibodies like Darzalex or Daratumumab, Elotuzumab, and recently the approval of isatuximab. And there's newer agents like Selinexor or Belantamab, Melflufen have been approved for later relapse for these patients. Now, to talk about that in myeloma, we have many options for these therapies. We don't actually treat a relapsed myeloma, especially first relapse, with one single agent. We actually treat it with either a doublet agent, 2 drugs, or 3 drugs, which is the majority of the times. So you have to kind of have different classes and combine it, 2 different classes with steroids in order to make the right triplet therapy. So we have a lot of evidence that these type of triplet therapy really work very good. Unfortunately, the problem here is that with every single time we have a patient who relapses, we have a major issue with that. It's very difficult to get them in remission, And it's also, we have like what we call a short time of keeping them in remission. And every time they relapse, kind of new mutations develop, more resistance to the treatment actually start to evolve. And that is the main challenge that we face as myeloma doctors. So we always have to try to pick up newer treatments, newer classes of drugs that can be very effective in treatment of relapsed myeloma. But if I actually kind of get it right, we have a lot of options of therapy, but we have a problem, what we call the traffic. All these triplet therapy that we use, a lot of patients when they come say, well, the first relapse, what would I use? I have a lot of options. It's very difficult to choose which one is better. Now, some patients will think that's a good thing. Some myeloma doctors have to say, well, it's a good thing, but also we don't know which one is the best as efficacy. And that's a very important thing for me as a myeloma doctor. As you saw from the previous slide, is that the majority of the patient, every time they relapse, the remission time will shorten. So I want to try to choose the right regimen that can keep the patient in remission longer as possible. But the problem is that we don't have any effective randomized clinical trials that compare these 3 drugs versus 3 drugs. We do have a lot of options, but we don't know which one is the best. So the myeloma doctor have to kind of like look at the patient, look at the preference, look at the type of disease and the previous treatment that the patient have in order to choose the best option that the doctor believe it is the right option for these patients. Talking about all these options, I want to kind of like really focus on several drugs that really are the main core of these treatment for relapsed myeloma. Daratumumab, that Dr. Ganguly has said, it emerged really fast from really late relapsed myeloma. It used to be option as a monotherapy, and those who relapsed multiple times on several treatment was really effective. It's an antibody that targets CD38, have multiple mechanisms of actions to kill the cancer cells, including immunotherapy treatments, forcing your immune system to attack myeloma cells. Really tolerated treatment. Patients, have one issue in the past with it was the IV form, and I don't know how many patients still on IV. The first dose, I used to tell patients you have to stay in the clinic for 10 hours, and I mean, imagine like telling a patient about that because of the infusion-related reaction, and the rate was very slow in the first dose, and then after that 4 hours, subsequently the dosage or the duration of the dose dropped down. But now it's much better because the FDA approved a subcutaneous, an injection form of the Darzalex. So instead of like waiting 10 hours, the first dose usually we give the injection and keep the patient for observation between 4 to 6 hours. So we can avoid any possibility of reaction. And if they tolerate that well, then the subsequent doses just take the reaction and they can go home, So this is kind of like becoming one of the best options of therapy in triplet therapies. Isatuximab is also a newer treatment that we have actually approved by the FDA. It's really not that much different in terms of like, it targets the same thing that Darzalex target. And I have a lot of oncologists ask me if the patient progressed on daratumumab, is isatuximab a better substitution for that? And I answer very, very straightforward. There's no studies to prove that. You can try, but there's no studies to prove it. You can't tell the patient like, it works up to 30 or 40% because there's really no studies. So we are trying to see if there's any kind of studies that prove that doing the isatuximab after patient failed the daratumumab, can it work or not? We need more studies to show if it's really effective or not. Elotuzumab is another agent that we see in relapsed myeloma, and elotuzumab is another monoclonal antibody. What it does is actually really amazing. It goes to a receptor on the natural killer cell, which is one of your immune cells, and also that go and attach to the receptor called SLAMF7, and that receptor itself also is present in the myeloma cells, and it tries to kind of like put them very close to each other to force the natural killer cell to kill the myeloma cells. As a single agent, it's really not effective. But if you combine it with immunomodulatory drugs like Revlimid or pomalidomide, it's really effective treatment. And it proved that by the randomized clinical trials. Now, talking about that, we do have a lot of options of therapy. And as I say, all these options of therapy is really great that we can actually offer it to the patients. But sometimes we have to make the right decision by looking at the patient himself, the condition of the patient, the comorbidities, and also the patient preference. and what treatment the patient was on and he relapsed. So for example, let's say the patient was on maintenance therapy of Velcade and he progressed on that. What options you will choose? You can see there's multiple options, multiple trials that showed that, for example, Revlimid-Dix, carfilzomib Revlimid-Dix, elotuzumab Revlimid-Dix, and one of the options I kind of offer to patients who intend to kind of like travel a lot, and they don't like to come to the infusion center, Ixazomib Revlimid-Dix. That's all oral therapies. So all these options are really valid to give for these patients. And now, common question patients ask me, which one you think it's the best? They never actually compare each one of them together. So I never actually answer that question. I have my own preference, but it doesn't mean my preference that it shows that preference it's more effective than the other drugs. But what if most of our patients are on maintenance therapy like Revlimid or IMiD-based therapy, and usually when they progress, it doesn't make any sense to put them on the same Revlimid-based therapy regimen. So we try to change it, and there's other options for that. As we talk about Darzalex and isatuximab, you can combine it with Darzalex Velcade-Dix or Darzalex or daratumumab carfilzomib-Dix and isatuximab carfilzomib-Dix as well. Some other options, which I don't know, we don't use it very often, but carfilzomib Cytoxan-Dix and sometimes, which I rarely use it, carfilzomib-Dix as a doublet therapy. If the patient have a lot of comorbidities, I might consider using that. So we have a lot of options even for those who progress after Revlimid. Pomalidomide-based therapy also is a good option, and it can be combined with Velcade, isatuximab, elotuzumab, and daratumumab. And all of these options, I kind of like save it and use it in those who are refractory to Revlimid, more likely. And you can see that we have all these options. But what we do here in KU is different. It's kind of like straightforward. If the patient progresses after the first line of therapy, we tend to kind of use daratumumab-based therapy. Any of the daratumumab-based therapy, whether Dara-Revlimid-Dix or Darapom-Dix, Dara-Carfilzomib-Dix, and also Dara-Velcade-Dix as well. And the isatuximab also is a fair one that we actually like to use. And there is a reason for that. The Darzalex and isatuximab, first of all, it's a well-tolerated treatment for all the patients. It can be combined with all other classes easily. It has been proven all the 6 randomized clinical trials that adding the daratumumab add more benefit in these patients and well-tolerated for these patients. So here in KU, we kind of like our first line after a patient relapse, the first line is considering Darzalex. In the past, it used to be very difficult with the IV daratumumab, talking to a patient that he should come and stay the first dose, the first day over 10 hours. Now with the sub-Q, it's much better, much easier to convince these patients to receive the Darzalex-based therapy. So most of our patients, if not all, are receiving Darzalex-based therapy as a first treatment. But what happened after that? Every single line of therapy, we move on. We have a lot of options. And every time you relapse, your chances for your myeloma to stay in remission longer becomes lower. We have a definition of triple class and pentaclass refractory. And for those to know what is triple class refractory, is that you have 3 different classes of myeloma, the 3 major ones. The monoclonal CD38, which is either Dara or isatuximab, the immunomodulatory drugs, which is Revlimid and pomalidomide, the commonest, and the proteasome inhibitors, which is Velcade and carfilzomib, that we kind of use, or Laro. If you're refractory to the 3 of the 3 classes, then you have what we call triple class refractory. If you're refractory to 5 of the drugs, which include both immune modulatory drugs, Revlimid and POM, and both proteasome inhibitors, carfilzomib and Velcade, and one of the CD38, which is either Dara or isatuximab, that's penta-refractory. Why is that important? Unfortunately, the importance of that is the survival. Those who are triple refractory, the survival after these is 9 months, the median survival. Those who are penta-refractory, the median survival is 5.6 months, meaning like we need to find a better treatment options, instead of reutilizing the other drugs, trying other options, alkylating agents. So the FDA actually approved multiple treatments. And I want to actually skip this one, actually, the selinexor. I want to talk about that because that was one of the drugs that got approved by the FDA. And it was the exportin, which it's actually an exportin or XPO1 inhibitor. And what it does, that the XPO1, it really actually, it works as an exporter to transfer the tumor suppressor proteins from the nucleus and the glucocorticoid receptors from the nucleus to the cytoplasm. So the selinexor inhibit that and kind of like causes retention of these tumor suppressors proteins and the glucocorticoid receptors inside the nucleus itself. Now, clinically, is it effective or not? So it was actually studied in the STORM study. And the STORM study actually kind of evaluated that, finding that the response rate in those who are triple and penta refractory was ranged between 25%. Progression-free survival was around 3.7 months, but it has side effects about thrombocytopenia, nausea, vomiting, that patients need to be on anti-nausea medications, anorexia, weight loss. However, it has to be given with steroids as a single agent. The response rate actually in the initial studies was 4%. So the drug is really effective when you give it with steroids. Some other studies that got approved was the Boston trial with selinexor Velcade-dex to treat it after first or second line of therapy is not really actually something that we really like to consider because we have a lot of options, the daratumumab-based therapy and isatuximab in addition to elotuzumab. So it's very difficult to put the selinexor Velcade-dex with these other options of therapy. Another drug that FDA approved also is for relapsed refractory myeloma after triple refractory myeloma after patients who are heavily treated is belantamab. And belantamab, for those who have to know, I want you to remember the word BCMA, B-cell maturation antigen. That's the target on the myeloma cells. That's where the belantamab and the CAR T cell that we're going to talk about and the BiTEs really work very good and effectively against these. The belantamab here, actually, I want to just say that it actually is an antibody that actually attached to chemotherapy, very toxic chemotherapy. We call the MMAF or monomethyl auristatin F. Like imagine that's a very toxic chemotherapy. Once that antibody attached to the myeloma cells, it tried to enhance the immune system to attack the myeloma cells, but also inserts that MMAF inside the cancer cell and causes destruction of that. The initial results as a single agent show that it was showed a response of 67%. But when they tried it on triple refractory and penta refractory treatments, the response rate was about 35%, with a progression-free survival around 3 months. Now, the good thing about it, it's an IV drug that it's given every 3 weeks, but it has side effects, eye toxicity, and we call it eye toxicity because for some reason it causes some issues in the cornea. So these patients have to be seen by an eye doctor every 3 weeks prior to every treatment. There's no surgical intervention needed, and the only way if the patient start have any signs of this eye toxicity by the ophthalmologist is to stop the treatment and evaluate it, and in order for it to be reversed. Another treatment that got approved recently is melflufen. And melflufen, for a lot of people, just to understand, it's kind of like one of the highly alkylating peptide that is significantly, was made in order for it to focus on the cancer cells, enter the myeloma cells, and there's a specific type of enzyme that will try to dissect it in order to kind of force that chemotherapy to go and kill the myeloma cells. So it tries to kind of focus all the cancers, the chemotherapy, to go ahead and kill the myeloma cells. Now, as effectiveness, in order for it to kind of kill as much as possible myeloma cells and have less toxicity in your all normal cells. The FDA approved it based on the Horizon trial. The response rate was 29%, being progression-free survival was about 4.2 months. Overall survival was 11 months. And those patients were triple refractory. So the only issue about it is it's the cytopenia, which is white cells below, platelets will be low, and anemia, and patients have some anemia. However, that was also the third drug that got approved. Now, we do have great options here now, and the FDA just recently approved the CAR T cell. And for a lot of people to understand what is CAR T cell have been evolved in the past, in order to treat lymphoma and acute lymphocytic leukemia. And we were thinking about, can this be a great option of therapy for myeloma? And I think there was some results about CAR T cell to focus on CD19. And I just want to go and talk a little bit about what is CAR T, is chimeric antigen receptor T cells. And what is that actually? So what the scientists do is that they use your own T cells and they kind of manufacture it. They put like what we call laser tag. And this laser tag will attack the myeloma cells. In normal life, what these T cells have to do in your attack infection and attack the cancer cells. But some of the cancer cells are very clever enough that they can actually hide from the T cells. So what the scientists kind of like did is that they took these T cells, manufactured it, and added these laser tag. And they choose like some target therapy. Now, the target therapy they liked in myeloma was the BCMA, B-cell maturation antigen, the same thing that belantamab chose. And the results of that was really amazing. So after they take these cells from the patient and manufacture them, they try to amplify it, make more of these T cells. And then they go ahead to the patient, and after it takes them 4 to 6 weeks to kind of like do all this process. They give this small dose of chemotherapy, what we call lymphodepletion, and the 2 chemotherapies we use is one called fludarabine and the other one called Cytoxan. And after that, we infuse these T cells back to the patient. And it goes and finds the myeloma cells and attach to it, and through some mechanism of actions, by producing cytokines, it go ahead and it destroys the cancer cells. That's what normally happens. So the question here is that as great as this mechanism of action, is it safe, A? Is it effective, B? And how effective it is? That's a very, very important question. Number one, is it safe? It has some side effects, but are these side effects worth it and manageable? So we're going to focus on the KARMA study because that was the study that the FDA approved, the treatment, which we call ide-cel. They have side effects for your counts. It can drop your neutrophil counts and platelet counts. However, if patients have these counts dropping, it can be also recovered. But one of the more important side effects that we actually notice about these patients is something called cytokine release syndrome. These T cells tend to, when they attack the myeloma cells, tend to produce these cytokines, which is interleukin-6, tumor necrosis factor, interferon gamma, and these tend to actually be maybe overexpressed, and causes some side effects. These side effects could be very mild, some fever, some chills, that you can give a small dose of Tylenol and the patient is doing better. It can be very severe to the point that the patient's blood pressure drop down and you need to admit the patient to the ICU, and it can cause some shortness of breath that patient need to be on a ventilator. So we have a grade for this system. Thankfully, the grading here for this, showing that the grade 3 was about 5 to 6% only of the patient, which means like their breathing is worse and may need ICU. So the majority of the patients who get the treatment, most of them, when they get the cytokine release syndrome, they can be treated very easily. So the reason why we admit the patients for this is to monitor for the cytokine release syndrome. Another side effects we kind of look at is the ICANS, which is the neurotoxicity caused from the CAR-Ts. And although, these neurotoxicity could be ranged between simple headache, confusion, lethargy, it could be worse to seizures and cerebral edema. And that's where, more intervention needed, like steroids and all these stuff. So the grade 3 good thing about it, it's really actually low. It's about 3% of these patients who can get that. Of course, we can see infection for these patients because you're dropping their counts down. And we also always notified patients that, with the cytokine release syndrome, in case they have it, we have some drugs that can reverse it, like tocilizumab, steroids, and some also other medications. Now, as safety, in my opinion, with those patients who are triple and penta refractory, I think that's really a great option, it's really safe, manageable as well. As efficacy, again, for those patients, so let's focus on the KARMA study, you can see that the response rate for these patients is around 73%. Now, for me, I'd never compare oranges to apples. And the reason for that, because, a lot of myeloma doctors will do it, say, let's compare this one to the STORM study where you have selinexor 25%, this 73%. It's not fair to do that. But as a myeloma doctor, when I see that response rate in patients who exhausted all their options, 73% is really impressive. Not only that, 33% of these patients went to complete remission. That is really great after you relapse after multiple lines of therapy. Now, a lot of patients, unfortunately, that use the word, is this curable or not? It's not curable. That's the disappointment, because patients will relapse after that. And the relapse range, and it depends on, what response you got. So those patients who, in general, all the patients who got the KARMA, the treatment, and regardless of what response, 9 months was their progression-free survival. But those patients who got complete remission, it went up to 19 months. So it depends on your response. If you go deeper response, you can stay in remission longer. Now, I know it's a little bit disappointment that these patients still relapse, but if you look at it from a different end, this is very good and a great start. And there's a lot of options that they're trying to hopefully improve the efficacy of this CAR T cell to make it more effective and last longer. If you look at other positivity, this is a one-time treatment. So if I want to look at the worst scenario, a patient staying in remission for 10 months after one treatment and being in the hospital for 7 days, is it worth it? Yes, it is worth it. Considering that the other options, like you have to be on the treatment, you have to stay on the treatment, you have to come more often, the side effects, if you stop the treatment, there's a likelihood that the disease will come back. Here, you're talking about one-time treatment. This is a great break for the patient. This is a great quality of treatment, I say, for these patients. They can, do whatever they want to do, visit. During the pandemic, we have a lot of issues, for these patients. Like we have to stop most of the treatment because we were a little bit worried about that. So imagine yourself getting the CAR T cell. You don't have to be worried about getting your treatment. You don't have to be worried about stopping any kind of treatment to go to any procedures, any surgeries. These are things that we look at it as a positivities. Now, a lot of people ask me about, what about the manufacturing? Is that something you're concerned? Of course, I'm concerned about it. 4 to 6 weeks, it's really too much. And we're not happy about that. We want something very fast. And the reason of that, because every time you stop the treatment, patients can progress very fast and can cause some renal failure, and we might not be able to get these CAR T cells back to these patients. So we want something on the shelf, hopefully that will be available. And we have that. The BiTE actually have been proving itself, which is bispecific. This is actually one of the things I want to say. It's a bispecific T cell engagers. And what is this? This is really actually a very great treatment for multiple myeloma. And what they use is an antibody that actually holds the CD30 T cells and the myeloma cells, which is BCMA, and try to bring it very close to each other for the T cells to go ahead and attack the myeloma cells, same as the CAR T cell does. So you don't have to kind of like take the T cells out and engineer it. You just go ahead and give a drug for these patients. And these results, the initial results are really impressive with the durable response rate and all this stuff. So this could be a really great option for our myeloma patients. Now, I kind of like want to talk a little bit about other clinical trials. And unfortunately, I think I gave the wrong slides. But anyhow, I want to say that these clinical trials actually are available for myeloma. We have trials for smoldering myeloma, trials for maintenance and relapse and newly diagnosed myeloma. Common question I receive from a lot of patients in regard to these clinical trials that we have, and also we still have a lot of CAR T clinical trials and BiTE trials. The common question I receive from patients is that they are scared of these trials. They think they're a guinea pig. I want to remind a lot of patients that 20 years ago, the patient survival was very short due to the fact, that we didn't have great options. Now, because we have a lot of options of therapy, we see survival up to 15 years. We're hoping that we're going to achieve cure. CAR T cell didn't get approved without the hard work of our patients who participate, and the institutes who built it, and the pharma company who actually contributed with that. It got approved because we worked very hard, and we saw the great results, and we are hopefully going to see a real hope in the future of multiple myeloma for treatment for these patients. We do have, we do have a great clinical trials for CAR T cell, and our program is open right now also for commercial CAR T cells for myeloma patients who are triple and penta refractory. By this, I'm going to end my last slide because the last slide, I think it's not relevant to this one.
Okay.
Thank you very much.
What a great talk. Great presentation and pacing for all of us. For those of you that might have missed a slide or two here on this presentation, which is another very important presentation, I'm going to remind you again that it's going to be up on our website. If you have additional questions after you review that, you can call our toll-free number, 800-452-2873. To remember that, it's 800-452-CURE. And you leave a message there, and one of our info line people will get back to you in a reasonable amount of time. So you have many, many options here, including myeloma.org. So with all that being said, let's look at some questions. Dr. Abdallah, do you see some of these questions on your chat box there? Okay, he might have fallen off there. Sid, can you answer some of these questions? I'm not sure we're. Oh, there's Abdallah.
Oh,
Dr.
Yeah, I can hear you. Can you hear me?
Yes, I can hear you now.
So some of these questions were answered by Dr. Ganguly, so I want to see which questions are related to the relapsed myeloma.
Dexamethasone with CAR-T on the first line of therapy.
New diagnosis, I think you say.
Yeah, okay.
Could you theorize what kind of response a new diagnosis function would? Well, it's a great question. So I think if I may actually say that this is actually a question about using and utilizing CAR T cell in newly diagnosed myeloma as a first line of therapy, and also a question about is there any clinical trials in this field? Yeah. I think there have been a lot of question mark about using CAR T cell in newly diagnosed myeloma, and when you see something is really working very great in relapsed myeloma, and especially in those who are heavily treated, and you want to try to move it really upfront to see if it actually can last longer. There is some trials that they're trying to put CAR T cell and to utilize it. It's very difficult to substitute stem cell transplant, and I'll tell you the reason why. The last study that we saw from the IMF, it was a very impressive trial that they did RVD transplant and followed by 1 year of maintenance therapy Revlimid. The progression-free survival for those patients who got transplant was close to, in 8 years, was close to 40%. Meaning like CAR T cell really have to prove itself to compete with stem cell transplant. I don't see that's going to happen anytime soon. I think if they want to prove themselves, they have to go and have a head-to-head to compare themselves to transplant. I wish it can actually substitute transplant, but it's not a guarantee because transplant have been so far unbeatable. Nothing had beat transplant any time, any head-to-head studies, period. So if CAR T cell wants to go to that direction, they have to have a head-to-head. But in my opinion, I think the best scenario is that which they're doing for those patients who are not eligible for transplant to kind of utilize CAR T cell there. I think that makes a lot of sense to kind of do that. Are there clinical trials? Yeah, there are. I think KU also is opening a clinical trial for upfront CAR T cell, but they're for these patients. We're still trying to open that trial. So we actually are seeing that is going to happen. Definitely CAR T cell is moving to earlier relapse. We are seeing that. And they're trying to compare it head-to-head with other triplet therapy, which is also important because we want to see how effective it is. To answer that question is that newly diagnosed myeloma, it is going to be challenging. It's not an easy thing just to go ahead and replace it because it looks great. They have to prove themselves because stem cell transplant has been there for a long period of time. And so far, all the trials have shown that they're all inferior to stem cell transplant in keeping remission.
Great answer there. That's a lot of information.
Another question, I like this question about multiple myeloma in the form of plasmacytoma, and we have to identify what's plasmacytoma because sometimes it is not an easy definition. Like you see it in the bone, is that really aggressive? Versus if it's in the liver or other soft tissues, it's aggressive. I treat them as a high-risk myeloma. And to be honest with you, is it different? We have a lot of question mark about that. What treatment the patient had in the past, for example. So, for example, if the patient relapsed with an extramedullary disease on Revlimid, I will try to use Darapomdex on these patients. If they relapse on proteasome inhibitor, of course, I will try to utilize these drugs and newer agents. One of the things I experience is that these plasmacytoma are still sensitive to alkylating agents. As a matter of fact, to prove that how effective it is, the studies from the relapsed refractory myeloma from the Horizon that use melflufen, they look at the alkylating agent, the melflufen was effective in the extramedullary disease as a single agent. So that's something proving that, in my opinion, if you want to, if the proteasome inhibitors, the monoclonal CD38, and the newer immunomodulatory drugs doesn't work, using alkylating agents like Cytoxan or melflufen will make a lot of sense in these patients. So I'll say, if I want to be, definitely I'll need to be aggressive with these patients, but I'll try to kind of utilize a triplet therapy for these patients. Stem cell and T cells after transplant. Okay, I think one person, what is the possibility of using both stem cells and T cells after a transplant? Like after relapsed myeloma?
I can take that if you want me to, Dr.
Yeah, please.
Abdallah. So the question is very pertinent, and we are trying to answer that to the CTN, which is the Clinical Trial Network for the BMT groups. So there's a CTN 1901 and 1902. 2 trials are coming pretty soon, where we're thinking of using CAR T or T-cell therapy after the transplant, and the goal is to mop up the minimal residual diseases. So the question is very pertinent. Can we use the stem cell transplantation to put a deeper remission, and then whatever is left behind, get it out by a CAR T therapy? That's the question that they're going to answer. So it is coming in future. It's a good question, and yes, it is in the horizon.
So I have also 2 questions here. Is that have you is there any studies done that look at follow-up treatment after CAR T cell? Yes, we're starting doing these studies. As a matter of fact, now we're focusing on trials to show that patients who progress after BCMA CAR T cells, and also there are some studies to actually try to re-challenge those patients who actually, let's say, stayed in remission for 1 or 2 years in CAR T cell, to re-challenge them with another dose of CAR T cell. So they want to see if actually more than one CAR T cell can be worked on. And I think that is kind of like a reasonable that we're going to hopefully we'll have answer. Do I believe CAR T cell will lead to a cure? It's too early to say that. And I would really actually be very careful about the word cure right now. Very careful. Because every time I mention CAR T cell, people associate it with cure. As Dr. Ganguly mentioned, like we have great results from transplant, but even patients who go to MRD negative, some of them still relapse. It is a great start. Let's start it from this. Let's put common sense here. When I show you the studies that relapse refractory myeloma, you guys saw that the survival after triple refractory was about 9 months, and penta refractory was 5 months. That's a survival. And you're talking about the response rate range in all the drugs that were approved by the FDA between 20 to 30%. The CAR T cell kind of exceed that, 75%. That's a good start. 9 months in general, and those patients got complete remission 19 months. That is really impressive. And that's a great start, meaning like we still have a lot of room for improvement. And I think that's great. But imagine like all of this, we're changing the landscape of treatment of myeloma by utilizing the CAR T cell. So I think it's too early to say the word cure. I would actually not use it very often, that until we have more studies for these patients. Is it going to be used up front and change also? We're going to need a longer follow-up in order for us to make that decision.
Okay, one more question so we can keep on time.
So there's another question. There's a lot of great questions. I'm so sad I can't answer all of them, but can drugs used in some trials keep the patient from using the drug for future treatment? I think that's a challenging question for me to say that. Let's say, I'll give you an example. If you were on, a very simple one, let's say you got belantamab and or you got daratumumab in the past days as a single agent, and in the clinical trials, and you progress on that. Would I use it as a combination therapy? I have used that all the time, and it worked very good. So you can use it, but in other clinical trials, I think it will be a no answer. Most of the trials will prevent you from entering the clinical trial if you have utilized one of their drugs in the past. But in real world, I think you can reutilize these drugs in a different way. For CAR T cell patients, some patients tell me, I got CAR T cell and I progressed on that. We have to look at what target was it. Was it CD19 or was it the BCMA? And we also have to look at the dosage, because the approval dosage was 300, 450. So if you got, let's say, 50,000 or 150, I think, in my opinion, that you should be actually eligible for getting a CAR T cell in real world. So that will be my opinion for this reason.
Okay, what a great session there. Thank you, Dr. Abdallah. That was a lot of information. So remember, you can get this on our website at myeloma.org. You'll hear more about that as time goes on. So with that being said, another good friend of mine, I'd like to introduce Kevin Brigle. He is going to talk about how to manage myeloma symptoms and side effects. Take it away, Kevin.
Thank you, Kelly, and I hope the weather is beautiful in Kansas. It's absolutely gorgeous here in Richmond today, and right in the upper 60s, and thanks for inviting me to talk today. So we're going to talk about symptom management and symptoms related to not just the disease itself, but also mainly to the side effects of the therapies. I've seen some of those questions in the chat box already about neuropathy and things like that. This is a slide deck, or part of a slide deck, that's put out by the Nurse Leadership Board of the International Myeloma Foundation. And the main goal of the Nurse Leadership Board is really to patient education and nursing education, to educate those nurses who take care of patients who treat multiple myeloma. And again, we really focus on symptom management as much as anything. And so this is the title of it, Be the Commander of Your Galactic Journey, and this is the constellation of symptoms as well. So when we think about symptoms that are, I guess, experienced by patients with multiple myeloma, they can be caused by two things. Of course, if we look on the left, we can see the myeloma itself can cause symptoms. Calcium elevation can cause fatigue. We see infection. We see anemia associated with that. And we also see symptoms related to the treatment. That's over on the right. So we see the myelosuppression, where we can get infections, we can get fatigue and things like that as well. And you can see they're not mutually exclusive. And when patients are diagnosed, typically what they're experiencing are symptoms related to the myeloma. But as we get that myeloma under control with the treatments, the various treatments that we use, then, of course, then we have the side effects related to the treatments. And so when we think about treatment of myeloma, we're not thinking about just the treatment that kills the myeloma cells, but we're also talking about some supportive care as well. And that is treatment to alleviate some of these other symptoms that you see associated here on the left, or on the right, excuse me. All right, so these next three slides, and this kind of been, I guess, expressed before, but these next three slides are really looking at the approved drugs for multiple myeloma. And there are actually what I would call 14 newer agents, and they're actually in 8 different categories. So we have quite a few new ones. There's a couple of older ones which are listed in here as well, which are classic chemotherapy agents. But what we have here are the drugs listed across the top, and you can see on the red, we talk about the immunomodulatory agents, and on the right there is the proteasome inhibitors as well. Going down the left-hand side, we see neuropathy, thrombosis. These are all the potential side effects associated with these different agents. And so when we think about treating patients up front, we don't always also just think about, well, what's the best agents to use? We sometimes have to think about what are some of the side effects associated with that. So let's, for example, if a patient comes in with significant diabetic neuropathy, it might be difficult to use one of our proteasome inhibitors. One of our most common upfront regimens is Velcade, Revlimid, dexamethasone. But Velcade carries a pretty significant risk of neuropathy. And so the actual problems a person may be having already may be basically dictating what medications that we can use. So that might be difficult. Again, the immunomodulatory agents, thalidomide, Revlimid, and Pomalyst, which I think everybody's probably familiar with, those are all oral agents. The proteasome inhibitors, bortezomib, carfilzomib, ixazomib. We actually have sub-Q, IV, and oral versions there. Going to the next slide, again, Dr. Abdallah just talked about the monoclonal antibodies, the daratumumab, elotuzumab, and isatuximab. They basically harness your immune system to recognize the myeloma cells, and that's how they kill them. The nice thing about these particular agents is they don't have significant side effects, so they're pretty good from that standpoint. And so those are the naked antibodies. The other antibody which he talked about was the Blenrep, or the belantamab, which is a monoclonal antibody drug conjugate, and that is also an antibody which recognizes the myeloma cell, but as Dr. Abdallah pointed out, that carries a payload directly to the myeloma cell, and so it doesn't really harness your immune system to kill the cell, but carries a chemotherapy agent directly to it. In red here we have the HDAC inhibitors and the signs. Feridac and Exposio, better known for us as selinexor, is this last one most recently approved. These are probably the agents which cause us the most difficulty in terms of GI side effects with the nausea, vomiting, and diarrhea. Most of our other agents are really pretty good from that standpoint. And then on the last slide here, when we look at the list of myeloma drugs, we have some of the classic chemotherapy agents, the anthracycline there on the left, which is also known as Doxil. We have the alkylating agents, Cytoxan, and melphalan. Melphalan, I would point out, is the drug which you get when you get a stem cell transplant. So that's the drug which we use to basically ablate the bone marrow and try to kill all remaining myeloma cells in there. And so those are classic alkylating agents. We now have the alkylator conjugate, the melphalan flufenamide, or the Pepaxto, and I kind of describe that to patients as kind of melphalan with a slab of bacon added. And so the bacon makes everything better. And so what this conjugate does is it actually targets the melphalan more directly to the myeloma cell, so we get more directed killing, unlike just straight melphalan itself. And then the CAR T is listed on here as well, and that was just approved in the last 2 weeks. And so that's something very new and real as well. So when we think about all these drugs, again, we got lots of combinations, and I think that was pointed out. So when we have so many combinations, if we look at, NCCN guidelines, NCCN recognizes 46 different regimens that you can use to treat patients with multiple myeloma. So lots of options. And again, sometimes it can be a challenge to decide which option to use. But what I would point out is all of these agents come with specific side effects. And it's important to know those side effects, especially as we start going with triplets and quads, that we're actually adding more side effects potentially with each additional combination. And I think if we start out and we think about the side effects, probably the one which impacts patients the most, and we find in pretty much every single regimen, is the steroids, the dexamethasone, prednisone, whichever it might be. That's more or less public enemy number one. And why do we use steroids? Well, steroids work. They've been used since the 1960s. They're very good at killing myeloma cells. Unfortunately, you have to use them in very, very high doses to achieve that cell kill. And so there's a lot of side effects, and I probably don't have to go over a whole lot of them. They're listed on the left. Probably the biggest ones, the irritability and mood swings, then difficulty sleeping. That's the most common complaints we get. But of course, people can get heartburn with these, weight gain. For those people who have diabetes issues, elevation in blood sugar. So for us, when we think about all these, how do we manage those steroid side effects? And that can be quite the challenge. One of the things that we talk about is having a consistent schedule, taking them in the morning or in the evening. Very often we have our patients take these drugs in the evening prior to going to sleep. By the time they really exert their effects on the central nervous system of the brain, it's time to get up in the morning. If you usually take these steroids early in the morning, you're going to have a very difficult time sleeping that night. We often tell patients, pick a day of the week that you want to be taking these, and let's work with that. Some patients, obviously, if they're working 5 days a week, they may not want to do this on a Wednesday, but might do it on a Friday, so that Saturday can be a little more less of a challenge for them with their work schedule. Certainly take these with food. If you have acid buildup, which is something that's going to happen with all steroids, we have over-the-counters like Zantac and things like that. We have prescription medications as well. And then often we have to actually prescribe other medications as well, because these do suppress the immune system a little bit. Sometimes patients are going to be susceptible to shingles or thrush or some other infections. And very often other medications we may have to actually prescribe would be sometimes anti-anxiety medications to help patients get to sleep at night. Other times we bring in the primary care provider to help us with patients who have diabetes, and patients who may not be on insulin may have to be on insulin during the times that they take their steroids as well. So a lot of problems associated with that. The only good news I have is that basically once your myeloma gets under control, we can decrease the dose of the steroids, and rarely do we ever use any type of high dose steroid in the maintenance setting then as well. So a lot of problems associated with that. And again, I think from patient standpoint, that's public enemy number one. Listed on this side is kind of a constellation of symptoms. We put these together: fatigue, depression, anxiety, because they can very often occur together. They all affect quality of life, your relationships, and a lot of different sources. Some of those sources can, again, just be due to the steroids, or we get, again, those that irritability, insomnia, and just, again, not taking care of all the other side effects can lead to these problems. So how do we manage this? Well, certainly we can manage it with some medications. For patients who are depressed, we can manage that then as well. But there are other things that are non-pharmacologic that are listed here. Certainly exercising within your capability. That's what we would like patients to do. The classic line, if you don't use it, you lose it. That's absolutely true. So we encourage people to be as active as possible. Certainly support groups, whether they're social, whether they're like a support group you're involved in today, or whether there's something from your church or synagogue, then we, again, those are very important then as well. And of course, some people, do fine with some over-the-counter supplements and things like that as well. We have a very nice supportive care clinic, which manages both psychological issues, pain issues, and GI issues and things like that. So if you have the option of a supportive care clinic, certainly I would see if we can get a referral to them as well. If you think about the problems that we as providers think about that are more public enemy number one, this really kicks right up there. One would be infection prevention and treatment if you do have a problem. Patients with multiple myeloma do have compromised immune function. Initially, that's due to the multiple myeloma, because that does compromise the immune system. And then secondly, as patients get treated, then we find that the immune system is compromised by the treatment which we're given patients. And so we always talk about good personal hygiene, keeping the hands clean, things like that, environmental control, always washing your hands, avoiding crowds. That's not so hard to do these days. We always had patients wear masks in the past. Everybody's doing that now. But other environmental controls, which I tell patients, is to think about when you're at home, those types of things that you use commonly, like the remote or a keyboard or an iPad or the refrigerator handle, those types of things that could spread germs as well. To clean those off on a very regular basis also. Certainly get the immunizations that you're due for. That's very important to prevent infections if you can. And then lastly, of course, sometimes we'll add medications in there as well for patients who are at high risk for infections. I am sure all of you have heard this from your oncology nurses, that if you have a fever of 100.4, that is something to be alarmed about. And if that continues, that's something that needs to be reported and taken care of right away. The other big one, which we think about as primary care, as providers, would be the possibility of blood clots, or listed up here, deep vein thrombosis and pulmonary embolism. Number one for us is actually preventing these from happening. And number two is, if they do happen, you need to recognize the symptoms. So it's really important that we educate about what those symptoms might be. Because a DVT, which is a blood clot in a large vessel, which would be typically in the legs, or a pulmonary embolism, which is a blood clot in the lungs, we have those symptoms. Those are medical emergencies that need to be taken care of immediately. There are certain risk factors that can lend you to having one of these types of blood clots: personal or family history, lifestyle issues, so obesity or inactivity, smoking can be a problem. Medications, patients who are on birth control have a higher risk of blood clots as well. So what are the symptoms? If we look at the symptoms listed on there, so we think about a DVT or a blood clot in your leg: swelling, tightness, ache and pain, change in color. And it's usually going to happen on one leg as opposed to bilaterally. So if you see this happening in one leg, that's a red flag and something needs to be brought to the attention immediately to a provider. From a pulmonary embolus standpoint, chest or shoulder pain, shortness of breath, anxiety, rapid heart rate, those are things that usually occur in a constellation as well. So again, for us, preventing it, if it does happen, recognizing those symptoms is really important. So how do we prevent it as providers? Well, as providers, we know there are certain medications that lend themselves to thrombotic events, and so if we go back to those three slides, which talked about side effects, we know the immunomodulatory agents increase risk of blood clots. Carfilzomib does, dexamethasone it does, and so when we think about that, we think about those different types of chemotherapy regimens and the risks there. And so how might we change those if we need to? For most every patient who is treated for multiple myeloma, they are on some sort of medication to reduce their risk of a blood clot. For most patients without any risks, aspirin is perfectly fine. For patients who have higher risk, Coumadin can be used, but we very often use the direct oral anticoagulant agents these days because they're much easier to use then as well. In terms of self-management, again, stop smoking, weight management is a big thing. More activity and exercise is just shown right below there for patients who are traveling. If you're traveling any distance in the car, get out on a regular basis and move. If you're in a plane, if you can get up and walk, I think that's more of a challenge these days because they want people to sit in their seats with their masks on. But certainly do those exercises while sitting in your seat to help prevent the blood clots and blood pooling in your legs, which can increase that risk. So GI symptoms, this is probably the one good part here, is that most of our medications that we use, with the exception of, again, the selinexor or the HDAC inhibitor, do not cause a lot of problems with nausea and vomiting. We do see problems with diarrhea and constipation pretty much with all of the medications. If we look over on the left, the diarrhea isn't always caused by just our medications that we give you, but sometimes look at your other medications as well. There's a list of things which can cause the diarrhea. Certain laxatives, antacids, some things over the counter can cause problems as well, certain things you eat. And so be wary of those things as well. Sometimes we don't always blame these specifically on the treatment. And how do we manage that? Well, certainly there are over-the-counter antidiarrheal medications. We do have some prescription ones if needed, Lamodal, Colestin, which is a cholesterol binding agent, which we'll use in patients who have really refractory diarrhea we can't get under control. And then fiber binding agents are great as well. When the fiber is in there, it actually binds on to the fluid and helps bulk up the stool. Increase your fluid intake if you're having diarrhea as well, because we don't want you to get dehydrated. Constipation, again, it could be a problem with our agents, but also it can be related to some of the other medications which taken over the counter, especially when patients are taking calcium or iron or vitamin D. So once again, increase your fiber. That's always a big thing. Those fiber binding agents, which you used for diarrhea, are great for constipation as well. Again, they hold on to water. That can help bulk up the stool and make that easier. And there are a lot of over-the-counter medications as well, which can help Docusate or Miralax or those types of things. Again, for nausea, we don't generally see a lot of problems with nausea associated with these medications, but we can certainly manage those as well. I think if patients have nausea, then we're really not doing our jobs. We've been managing all these diarrhea, constipation, and nausea for many, many years with patients with all forms of oncology problems. So we have plenty of great antiemetics. I often tell patients in terms of meals, big meals are a little bit overrated. If you can graze like a cow all day and kind of keep food in your stomach, that will often help as well. So we definitely have good ways of taking care of all these potential GI symptoms. And what about kidney function? Well, we always talk about kidney function with patients with multiple myeloma, and in the box listed down there, it says many patients will experience kidney function problems at some point. Probably about 20% of patients are diagnosed. They have some type of a kidney dysfunction. Some patients go immediately to dialysis. What are the risk factors for kidney dysfunction? Well, it's the active myeloma for starters. You can have those proteins, those light chains, can clog up the kidneys. High calcium levels can damage the kidneys as well. If you have other medical issues, let's talk about keeping those under control. Diabetes, hypertension, if you get dehydrated, all those things can impact your kidney function. And sometimes it can impact your kidney function irreversibly. So in terms of medications, we worry about certain antibiotics. We tell patients if they're getting CT scans to avoid contrast. Patients with diabetes, metformin can be toxic to the kidneys. We worry about patients taking NSAIDs such as ibuprofen and or Aleve and things like that. So use those very cautiously. So again, protect those kidneys as much as possible. For prevention, drink. Plenty of fluids. It doesn't have to be water. It can be anything. Pretty much anything you drink is 99.99% water. But again, stay hydrated. That's really going to be the big part right there. So treatment, well, initially treat the myeloma. If we treat the myeloma, then we can certainly help protect your kidneys. Some patients will start out on dialysis. And with some patients who are on dialysis at the start of their myeloma treatment, their kidney function can recover recover and they can actually get off of dialysis. Some patients aren't quite that fortunate, and they may remain on dialysis for a long time. But protecting the kidneys is going to be a lifelong issue with patients with multiple myeloma. Along with that, bone damage is a big thing. Now, we know that 85% of patients are going to experience some type of bone disease during the course of their disease. Now, not all of that's going to be symptomatic, but for many patients, it will be. So bone health is a really, really important part. So we think of nutrition, we think of exercise, those weight-bearing activities. We think of keeping your vitamin D level up. We check vitamin D on every new patient who's diagnosed with multiple myeloma, making sure that that level is up. Again, vitamin D is made in the skin and upon exposure to sun. And a lot of us don't get that kind of exposure these days for a wide variety of reasons. For those patients who are on the bone strengthening agents, very often your calcium can be low. So if approved by your provider, taking calcium vitamin D combination is important. And then we have the bone strengthening agents. Zometa or zoledronic acid is one. Pamidronate we used in the older days. And then the newest one on the market for a couple of years is denosumab. And that's really good for patients who have kidney dysfunction. The Zometa and the pamidronate can be toxic to the kidneys. So patients who already have kidney dysfunction, it's difficult to use that. The denosumab, however, is really good. So from that standpoint, and again, any new pain issues that you might have that do not go away, those should be reported to your provider. Here's the other big bad one, I think, behind steroids. This could be the other big bugaboo for patients. And that's peripheral neuropathy. And if you go back to those slides again of all side effects of those medications, we have a number of our medications which can cause peripheral neuropathy. And it's much like when we talked about DVTs, what's our primary? Our primary prevention. Prevent the neuropathy from happening. And then secondly, if you do get the neuropathy, report the symptoms to us. And I'll kind of explain why. But the symptoms, what are the symptoms? They're shown up here on the left. And I've heard everything from numbness, prickling, tingling, pain, walking on sand, just electricity, everything under the sun, which we'll be talking about peripheral neuropathy. And the thing about peripheral neuropathy is it can be reversed, at least early on. So if a patient starts to experience peripheral neuropathy, we can actually do some modifications which may help reduce that neuropathy or actually make it resolve. So how do we do that? Well, sometimes we can just reduce the dose. So if we have bortezomib, which is well known to cause peripheral neuropathy, at the highest dose, we can make a dose reduction then as well. And you should not worry about dose reductions, because if the peripheral neuropathy gets worse to the point where we can no longer use the drug, that's not effective at all if it sits in the pharmacy. However, a dose reduction of that drug works perfectly fine in patients if we continue to give that to you for a very long time, as long as it's working. What we really don't like to do is discontinue a drug that's effective and working, and we have to discontinue it due to a side effect that we have not managed. So we can do some dosing changes as well. Certainly keeping the skin moist, that's one thing which helps. So cocoa butter there. There are some supplements that people use, sometimes with success. I would caution the B6, because excess B6 can actually cause neuropathy on its own. Some people take some over-the-counter type of medications or things they found on the web. Those are perfectly fine, but we typically will tell patients don't take them on the day that you take your therapy, because a lot of those we don't know how they interact. And we always talk about a safe environment. And if worse comes to worse, again, if peripheral neuropathy gets bad, again, we can change your treatment, modify your treatment. But again, we do not want to, again, negate any treatment due to a side effect when it's working. And some patients, I will say honestly, get great success out of acupuncture. It's typically not paid for by insurance, but it's a good option for at least to try if you have the possibility of doing so. And then the last slide here is, I think, a big one for patients as well, is that pain prevention, pain management. Again, if we can prevent it, that's fine. Very often patients present with pain because they have lytic lesions, which are causing the pain, those bone lytic lesions, which are very common at diagnosis. So again, bone disease, the neuropathy, if it gets bad, can cause pain then as well. And so how do we manage it? Well, you prevent it whenever you can, quite obviously. And again, we don't want the neuropathy to get so bad that it causes pain. We always use bone strengtheners, again, those bisphosphonates as well. We do everything we can. We can do other interventions. We certainly have pain medications that we can use, and the type of pain medication we use actually depends upon the source of the pain. Bone pain is very different and treated differently than peripheral neuropathy is. or pain is secondary to peripheral neuropathy. And again, that complementary integrative stuff is really good. And if you have a supportive care clinic, they're great at managing some of these things then as well. And so I think I believe that's the last slide here, and that's it. Questions? Kelly, I'll take it back to you to moderate.
All right. Well, thank you, Kevin. I really like that slide deck at the end of this presentation. Or the presentations. It really puts a nice hand around the whole project and another aspect. Well, folks, listen, I want to get your feedback. You can, if you look at that bar that's under your, down at your lower part of your computer, you'll see a clipboard. So please commit this, please here, complete start again. Click here to complete the feedback survey. I was going to say something else, a foundation or something, but you can get this information, of course, on myeloma.org. And I'd like to go into the final Q&A here. Doctors and Kevin, I see about 45 questions. Let's say for number 45, who would like to take that one? Ola, you want to take that one, number 45?
Yeah, let me just read it. What's the least research? Well, there's no, so for osteopenia, osteoporosis, and smoldering myeloma patients, we don't have that much about knowing about Relapsed in smoldering myeloma and definition about that, in osteoporosis, I mean, I don't have, of course, osteoporosis, you have to treat that osteoporosis patient, regardless if they're smoldering or not smoldering. But if the patient doesn't have the osteoporosis, I don't see any kind of utilization of using any of the bisphosphonate for these patients. So we have to kind of go with, with kind of evidence. I don't know if Dr. Ganguly, do you have any information about using any bisphosphonate or Xgeva in smoldering myeloma without any, any utilization in these patients?
Honestly, I do not. Other than if the patient has a diagnosed osteoporosis with the smoldering myeloma. Just because of the diagnosis of the smoldering myeloma, I have not read any research on using either bisphosphonates or Xgeva as a preventative measure. Mm-hmm. I have not.
I know there have been some studies about that, but I didn't see any randomized trial to make us a little bit impressive about that, to be honest with you.
Now, there's a question number 41. Is shingles prevention necessary after receiving the Shingrix vaccine?
That's a very, very good question. The reason I want to answer that question is because I just had a patient this Friday calling in with shingles after having had Shingrix vaccination and had been on acyclovir prevention post-transplantation. So the answer is, remember, the vaccine trials were all on healthy volunteers. The vaccines have not been tested on patients, especially with myeloma and transplant. So we really do not know the extent of vaccine protectiveness in patients with myeloma. So in general, after the 2 rounds of Shingrix shot, the incidence of future shingles goes down, but it does not go down to 0. And I have had several patients coming out with shingles even after the Shingrix vaccination. So there is always a distinct possibility. If somebody has completed the Shingrix shots, I would say pay attention to any new blister or any new pain that is shooting or tingling in either the trunk or in the limbs, and contact your doctor immediately, because it could be a pre-shingles and shingles might be coming in a day or 2. So if you are not on acyclovir and completed the Shingrix vaccination, still there's a minority of patients who can still have shingles.
And that's no fun, is it?
That is no fun.
Let's see. Number 40, do you see decreased urine output on the day of RVD injection, and how do you manage fluids? Number 40.
Kevin, would you like to take that?
Yeah, I will. I don't know that we see decreased urine output on those days at all. I'm not sure exactly what you're specifically referring to. So I think on those days, I would keep your fluid intake just as much as you would on any other day. Revlimid is cleared by the kidneys. Velcade is not. And so I have not noticed that. Have either of you to Dr. Abdallah or Dr. Ganguly? Seen anything?
No, not really. I think, Kevin, you are right. But on the other hand, if somebody gets Skyprolis, then we definitely give fluid. In the first round, we sometimes give IV, but later rounds, we tell them just give hydration by mouth before coming to the clinic.
Right.
Question number 39. Has anyone had any success in alleviating and or dealing with kyphosis caused by compression fractures?
Kevin, you want to talk about vertebroplasty?
Yeah, and I think that's something that has to be done pretty early. So kyphosis is that kind of, I would describe it as kind of a hunching forward that you're going to get due to these compression fractures. And so the compression fractures can be alleviated at least early on if we can actually go in there and they can inject a plastic into there and actually increase or reestablish the size of those vertebrae. And so that can happen. Unfortunately, if you've had the compression fractures for a long time, that doesn't work so well. So very early on, it's very successful and very successful at taking care of pain as well, but not so much after these compression fractures have healed or been around for a long time.
Thank you, Kevin. We do have a question about the COVID vaccine. Is it safe for myeloma patients to take the COVID vaccine?
The answer is
either one.
Yes.
So the answer is yes, it is safe. Like anybody else, COVID vaccination can give, some headache, some fever, transient body aches, rarely anything serious. The incidence is probably 2 to 3%. But I would strongly recommend getting the COVID vaccine. The only thing that we do not know, because again, the same thing, the vaccines have been tried in healthy volunteers. We have not tried that on our patients. So actually, we are running a trial where we are checking the antibody before and after vaccine. So if someone is in a Kansas City area and wants to know whether the vaccine is effective or not, I would strongly recommend contact our KU Cancer Center and ask for Canine, C-A-N-I-N-E trial, which is trying to answer that question, whether the COVID vaccination is effective and how effective it is for our cancer patients.
All right, let's go to question 30. Could you comment on the challenges in treating post-BCMA treatment relapse?
Dr. Abdallah?
Of course, there's going to be a lot of challenges because we have less, studies about that. Now we're starting developing these studies. The challenges is going to be about, do we utilize other options? We go and review other treatments the patient got. Are these patients really triple refractory and penta refractory? So, and also what type of BCMA these patients got? Some of these patients maybe got, again, CAR T-cell just got approved last month, and not everybody got maybe the higher dose of the CAR T-cell. And some patients maybe got belantamab in the past. And I have some patients who actually stopped the ADC BCMA because of eye toxicity, or they decide they don't want to do it. So we have to kind of be very careful when we define these patients. It's kind of a new group of patients like the triple and penta refractory. The strategies is always depend, do you utilize alkylating agents? Do you use one of the 3 drugs that the FDA approved, like including melflufen, base therapy, or selinexor? It's going to be really a challenging question because these drugs were not actually treated. They were not used, or they were not actually utilized in the clinical trials after BCMA treatment. Now we're seeing some studies that they're actually specifying post-BCMA drugs. And these studies are going to actually answer us much better questions. Some of the bites actually they're talking about, that some newer targeted therapy, I think. In our institute, which I think that's what we do, we always take these patients to a clinical trial. We always have to utilize a clinical trial for that. But out of the clinical trial, we review all these treatments that these patients got, and we see exactly if we can reutilize these drugs or use newer treatments that the FDA approved. But we don't know, or we can't give them an accurate answer due to the fact that we have lack of clinical trials for this specific group of patients.
Yeah,
Thanks,
Dr.
Mike.
Abdallah, I'm going to absolutely echo what you just said. I would be extremely interested in knowing what BITE does after BCMA CAR T. So we'll see how that pans out.
Well, here's question 38. My mom has increasing pain around her neck, or around her back, and ribs leading up to being diagnosed. Will this subside when the myeloma numbers go down?
This basically goes to the same question that Kevin had already answered. We need to find out why there is pain. Is there any plasmacytoma? Is there any vertebral collapse, fracture that is pinching the nerves? And if that is so, then definitely we need to talk about early kyphoplasty, which is the cement injection in the collapsed vertebra. So that will definitely help the pain. And then, yes, the answer is once we start treatment, many of our patients from the potent anti-myeloma drugs, even dexamethasone has significant bone analgesic property. So the pain definitely we expect to improve as we treat myeloma, plus minus with or without kyphoplasty. So I would recommend finding if there is any place that we need to attend to by kyphoplasty and continue the myeloma treatment. And I think things will definitely get better. Will it be completely going away? Time will tell, but definitely it will get better.
Okay, let's go for the final question, number 52. The newly FDA-approved myeloma drugs, ABECMA and...
Idacel.
Go ahead and answer that question.
So they're talking about Idacel melflufen, if I'm not mistaken. Is the Bibextro is the melflufen? I think that's right. So yes, these drugs these treatments got approved, by the FDA, and do it apply to all myeloma patients? We have to be very specific about who are the patients that we really want to focus so that we can give the right treatment. And I think our clinical trials are very specific in heavily pretreated patients, these two types, triple refractory myeloma or pentarefractory. They can get the Idacel or Abicma. And I talked to Dr. Ganguly about that. We want to really actually make sure that it's safe treatment. It has some side effects. We just don't want, because our goal eventually is to benefit from these drugs for these patients. So not all myeloma patients may be able to take, for example, the Abicma, the CAR T cell. So let's say a patient have very important saying like performance status is 4, like he's on a wheelchair, not due to myeloma, due to other things, or he have unfortunately end-stage renal disease on dialysis. We might be very concerned about making things worse, so we don't have enough studies. But there are some issues we might actually argue with it. Like let's say a patient who have congestive heart failure, but it's stable and it's not decompensated, and the patient is doing fine, and we evaluate some classification, New York heart classification, that's one, and the cardiologist says the patient is stable. We might consider this patient is exempt, and we can take him to do it. A mild renal failure might be also very great to take these patients. So we have to really evaluate the main exclusion, because also these are clinical trials. They didn't include a lot of patients. So we might look at these. Again, we're not going to be very strict like the clinical trial, but also we don't want to kind of anybody who comes to the room and with a bad performance status, with a lot of high comorbidities, give them CAR T cell and causes harm for these patients. And the same thing apply to the melflufen drug as well. So we have to be very careful for all these patients. But where do we utilize it from all the treatments? After multiple lines of therapy, and we agreed 4 lines of therapy. That's our agreement, that after patients fail 4 lines of therapy that include the CD38, which is either the daratumumab or isatuximab, Revlimid or pomalidomide, and also proteasome inhibitor, whether it's Velcade, Ninlaro, or carfilzomib. So when you see this type of patients, this patient meets the criteria for the disease term for getting the Idacel. The other things is that to see if the patient is fit enough for getting the CAR T cell.
So one thing we must clarify, when the FDA approved indication says after 4 lines of therapy, sometimes it causes little confusion in people's mind. What do we mean by lines of therapy? I had received RVD, then I had transplant, then I have received LEN maintenance, then I had received Cyborg-D. So I've already crossed 4 different kinds of treatment. Not really. Lines of therapy means as long as the patient is on a particular path and the myeloma has not relapsed, that's considered as 1 line of therapy. So for example, somebody comes with myeloma and we start them on RVD, taken them straight from the RVD to transplant and then put them on LEN maintenance. That is 1 line of therapy. And then on LEN maintenance, if somebody relapses and then we change the LEN to say Kyprolis, Revlimid, Dex, well, that's the 2nd line of therapy. But if the patient gets a second transplant as a part of the KRD followed by transplant, then K maintenance, well, that is just another 2nd line therapy. So the lines of therapy and the number of the chemotherapies or therapies, they're different. So 4 lines of therapy has to be given before we can give the Abecma. So just be careful about the terminology of lines of therapy.
Good point. Very good point. Well, does anyone else have any last comments they'd like to add to our program today, which was incredible?
Well, I want to take this question number 43 because that's an interesting question. If that's all right with you, what is the impact of factor V Leiden on transplant or therapy? Well, factor V Leiden is a mutation that imparts hypercoagulability in somebody's vascular system. But if the factor V Leiden, you are just a carrier, that does not impart high risk. But if somebody has already had a clot, that definitely imparts high risk. So one has to be careful with a patient with factor V Leiden and past history of clot, giving treatment that can cause clots like Revlimid. We have to give a strong, what we call is a thromboprophylaxis, like prevention of deep vein thrombosis. So factor V Leiden and history of clot does pose a challenge when we use medicines that can cause thrombosis in patients with multiple myeloma. So my recommendation is if somebody does have factor V Leiden mutation with or without clot, be very clear to your treating oncologist and say that this is a condition that I have, and the oncologist will decide the proper treatment for that particular patient. So this is a very good question, and it has got strong implications in the therapy.
And, it goes to say that it's very important for the patient to get the right doctor, the right opinions, and so forth in here, because the treatments are very, very complex today. And that's why a lot of them are so successful. Dr. Abdallah or Kevin, would you like to say anything?
One of the major comments I would like to add, we have really great options of therapy. We have a lot of clinical trials. We would like to always utilize these clinical trials for our patients, whether it's multiple myeloma, maintenance, and all these stuff. So, kind of visit our website, try to contact our clinical trial department. We also have our CAR T-cell clinical trials and also commercial availability. Try to also contact us, to evaluate. Don't come in the last minute. Unfortunately, the patients have been sent to us after they become on dialysis, and it's very difficult to put these patients on either a clinical trial or the commercial CAR T-cell. So we really like to see these patients before they deteriorate very fast, after they're triple refractory, at least, or putting them on our data, on our list of patients to keep our eyes and watch them very closely. We've been successful in that since the CAR T-cell got commercially available here in KU, to get these patients and enroll them in the clinical trial or get them into the commercial CAR T-cell. So we would like to do it also for other patients as well.
Fantastic. Kevin, would you like to add anything to your presentation?
Yeah, I'd like to say that utilize your oncology nurses. They've been doing this for a good long time, and they have a lot of great information. So do not be afraid to bring up side effects to them, and anything they can't answer, I'm sure they will take to the providers. The next thing I would like to say is, Kelly, happy birthday.
Oh, thank you.
Yeah, and you know what, Kelly? I won't tell you this, but it's my birthday today as well. So
is it really?
Oh, wow.
It really is, yeah.
Well, you're much younger than I am, so it's okay.
Yeah, I don't know about that. So, but anyway, happy birthday.
Yeah, it's going to be a good one. The dinner and cake, so I can't complain about that. Well, gentlemen, I know it's a Saturday. I know you're busy. I know you're trying to take a break from work. I can't tell you personally how much I appreciate you taking the time to work with the International Myeloma Foundation and myself. I'm sure there's a lot of hand claps out there for your presentation. Thank you again, and we're going to go through the final credits here. Have a great day, guys.
Thank you. Thank you, everybody.
So the replays, as I said earlier, are going to be sent to you if you registered. And if you haven't had a chance to see them, they'll be up in about 24 hours. You can go to myeloma.org and look for RCWs, and you'll see it. Let's go to the next slide. This is something that's incredibly important. I've stressed this throughout the day. Please click on the survey tab and complete the feedback survey. This is important for us. This is important for the foundation, so we know if we need to address different topics or explain other things that are outside of what we're doing. We don't know that if you don't fill out the survey. And I'd like to thank personally Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Oncopeptides. I think I got it right. Thank you all for participating in the RCW, and we look forward to seeing you at another one. Have a fantastic day.